Good afternoon. Thank you so much, Richard and Al. It's great to be here, and thanks, SAGES, for the invitation. I'm going to talk to a topic that is going to become more and more common as time goes by, and it will be the conversion of sleeve to Roux-en-Y gastric bypass. I have nothing to disclose. These are the most recent numbers by the American Society of Bariatric Surgery. As you see, after the sleeve, the fastest growing surgery, bariatric surgery in the United States is revisions. It was fifth most popular surgery about 5 years ago, and right now it's in the top 3. Slight drop last year on the 2016, but the trend is fastest growing as about 10 to 11% of all bariatric procedures right now are becoming revisional surgery. Of note, this was predicted many years ago by the likes of Dr. Benotti, Dr. Garnier, that about 25% of all bariatric procedures at a certain point will be revised. So as the number grows, so will be the revisions. Our practice, and this is something that I found interesting, I don't know if you're familiar, the International Federation of Surgical for Obesity, IFSO, recently had a guideline, and they demand, or they actually ask their, as we do with the disclosure slides, now their surgeons have to put their makeover of their case mix, how much they do. Meaning, as you can see, this is the type of cases that we do at the Cleveland Clinic, but the idea of this is that you will have surgeons that do the surgery talk about the surgery, or at least you will know if the surgeon talking is only talking about the surgery and not doing it. So I think it was very original for them to come up with this. So now every time somebody presents in the International Federation of Obesity, they put a makeover or a case mix so you know exactly what their experience are. The idea of this slide was not that, but to show that in our practice is no different. About 11 to 12% of our procedures performed in the lifetime of our program has been revisions. And as you see, we're a high volume program. This is the curve the last time we checked and published about it. As you can see, it has exponentially growth over the years. And this based on our data from the Endoscopic bariatrics. As you can see, our bands have completely disappear. We haven't done one in the last 4 or 5 years. But on the same token, as the sleeve grows, so does the revisions. And the bypass is steadily shrinking a little bit. And at this point, we're performing almost as many revisions as we do in gastric bypasses. Now, what caused these revisions? There are 2 main causes: complications related to the initial procedure, chronically most of the time, but also acute will present, and failure. And I like to talk about it in 2 terms. One is failure, the other one is recurrence. Not being confused, failure will be unnecessary weight loss, and that's where we're gonna go, how we define success after bariatric surgery. Of course, the durable of the weight loss, the resolution or significant improvement of the comorbidities, and the improved quality of life with the patient, which is probably the toughest one to determine. A lot of patients with poor quality of life, just based on their weight loss, they're happy, but not once they detail their quality of life is not as good. On the same line, what is a failure? And this is where we go into failure or recurrence. And there is a trend, and I'm definitely on board on that trend, and I like to push it as much as we can to treat obesity like cancer disease. It's a chronic, deteriorating, disabling, and in some cases lethal disease, in which when we do the surgery and patients lose weight, when we talk about cancer surgery, after 5 years, patients do lose weight, the cancer is free. And then the patient comes back. Nobody says that the initial surgery failed. We talk about recurrence of the cancer. Bariatric surgery is not different. We do surgeries where patients lose a massive amount of weight, that certain percentage of these patients within a certain amount of time will regain weight for many reasons I will detail. And that is not a failure of the surgery. That is a recurrence of the chronic condition, which is obesity. So that's where I like to differentiate what is a failure, which is inadequate weight loss. When we define the failure, how long do we have to wait to say, you know what, they didn't lose enough weight, it is truly a failure? Or how much weight do you need to lose, not to lose, to consider it a failure? Then if we're going to talk about recurrence, How much weight regain is enough for us to talk about it? There are some certain numbers that have been thrown there and studied about the 50%. Is 50% excessive weight loss is kind of the cutoff in most of our papers and studies, but still it's not debatable what if there are resolution of comorbidities. Who cares about that number if that is the bottom line of any surgery, is the improve or cure of a disease? And again, the leaks, the fistula, debilitating morbidity, is that really a failure, or is just the nature of the surgery itself a complication? And the reasons for the failure are three, if you want to group them big time. One, surgeon dependent. This is an error in technique or an error in judgment. A badly designed surgery or badly done surgery. Then you have the patient dependent, which refers to the patient follow-up and the patient's how they follow up the treatment and how they follow up on the surgery itself, and the nature of the disease. Obesity, we know, is a multifactorial disease in which many causes are going to be related to the regain of the weight or to the not enough weight loss. So it's a complete multifactorial disease that brings the conversion. So we go first to the revisional options, and we know none of them, the ones that you've seen here, from banding to trimming to placation, none of them have been proven to be very successful, or in some cases even adequate, specifically the banding of a sleeve. And then we have the ones that take us to the topic today, which is conversion options. The most common, and we'll see the studies about it, is the Roux-en-Y gastric bypass. But the duodenal switch is not too far. Even though you saw in the numbers that the percentage of duodenal switch is smaller than it used to be, if you go to the absolute numbers, we're performing more duodenal switch now than we were doing in the past. So it's a give or take. We're just performing more bariatric surgeries. But the absolute number of duodenal switch, which is a highly complex surgery not done by many people, and still arguably the best possible long-term treatment for obesity, and definitely the best treatment for super obesity, is another option of revision, and we're going into the malabsorptive options. But there are two new players, and I know I'm talking about the gastric bypass, but it's important that we mention the one anastomosis gastric bypass, which is like the seventh name that they give to this surgery. It started with the mini gastric bypass, the sleeve bypass, over and over, but now this is the name that I think will stay, which is a one anastomosis gastric bypass. And now there is a variation of that surgery that kind of combined duodenal switch with the one anastomosis, which is the single anastomosis duodenal interposition. And again, the bottom line is these two last surgeries are extremely popular right now outside of the United States. It is still considered as an experimental procedure in the United States for many, many reasons that we don't need to discuss, but one of the few ones is there are a lot of questions about the studies and the outcomes of this surgery still, and so more data is requested. But I will say within the next 3 to 4 years, we were going to see many, many of these revisions that used to be sleeve to gastric bypass to be converted probably to either one anastomosis gastric bypass or a single anastomosis duodenal interposition based on the amount of surgery that is being done outside of the United States and based on better data, better results that we're going to receive. I do not perform any of those, by the way, any of the single anastomosis bypasses, but I'm very familiar with the amount of them getting done outside. So the conversions, the revisions, mostly in the restrictive procedure. This is from the next to last consensus about the sleeve. We see the restrictive options up to 60% were revised. The combined, meaning the mix, the malabsorption restrictive, up to 20% were revised. The malabsorptive less than 5%, not because they're very effective, just because they're very complex and there is not much to revise there and nobody wants to touch them once it is done. But then this is the first time that they talk about revision of the sleeve, and in that 3% plus minus 6, so if overall in the worst case scenario about a 10% revision rate of the sleeve. Again, this is because this was earlier on the sleeve era, but this number we've seen has increased. Where did those revisions go? The first one was half of them were gastric bypass. Again, the duodenal switch, which seems to be a natural revision of the sleeve. The re-sleeve was a valid option. And then goes to more sophisticated, as you can see, the mini gastric bypass, the single anastomosis, the SATI, and other options. This is based on that consensus. In the Montreal consensus, about 100,000 patients, 3 of the most common contraindications were related to reflux. And the reason why I'm bringing this up is because we're seeing that the revisions of the sleeve to gastric bypass in many places are becoming most common
due to reflux than to weight regain. Even though at this point, again, this was a little bit earlier into the accelerated phase of the growth of the sleeve, still it was twice as much revisions done for weight failure or recurrence than it was for reflux. But we see that that number has progressed. This is our own experience at the Cleveland Clinic with the conversion of the gastric bypass. This is the series of our first 1,000 sleeves, and we studied them. As you can see, 1/3 of these patients were not from our practice. 1/3 of these patients were treated, if were done for reflux, the revision to sleeve to gastric bypass, and less than 1/3 was for failure of weight loss. Not because our patients lose more weight or weight than anybody, it's just they didn't request a revision. The patients that regained weight were not interested in the second step many times. So it's not an indicative of that, of the low prevalence of revisions of the weight loss. It's just the patient's choice at that time. But we see that reflux seems to be the Achilles heel of the sleeve and the main reason for conversion to gastric bypass. Of note is we have a short follow-up of these patients, less than 3 years, and the excessive weight loss on the second step, and that correlates with many of the studies. Some outside the United States are much more generous on the excessive weight loss, but we've seen most studies quote between 30 and 40% excessive weight after these conversions. So don't expect a result as a primary bypass when you convert these sleeves, but usually the technical aspect of the surgery is a bypass. Pretty much you go across the sleeve and develop a bypass. It's not technically too challenging in that sense unless it's done for a complication, but otherwise that's pretty much a review of the conversions of sleeve to gastric bypass. Thank you very much.